how do you make a decision to fuse somebody? Because I think you probably know as much as anybody else really in the world about, because you've looked at this really critically, you know, and trying to make that decision. So what do you do?
Well, I appreciate that.
Today.
You know, one of the things I heard, which resonated very much with me, was what Greg said. And, you know, I think over time in my practice, that has been where I have moved. Is I try to sit down with a patient and have a conversation about what their expectations are from surgery. And I think I've also tried to, as much as I can, get a better understanding of what people mean when they say they have back pain. Because one of the struggles that I have is you look at these studies and you look at, you know, this, you know, VAS score back pain, you know, of 7 or 8. I mean, what does that mean? And that means a lot of different things to a lot of different people. And a lot of back pain that gets described on these questionnaires is claudicating buttock pain. And that's different from mechanical structural back pain. And so I've tried to, you know, in taking histories with patients, try to really understand that a little bit more. Asking questions about, you know, when you stand up, you know, how does your pain feel? What are the things that really relieve this type of pain that you have? When you lie down, is it fully relieved? When you're carrying anything, is it worse? What's the character of it? I'm looking for signs of sharp pain, pain that's induced by motion, to get an understanding of whether they, as a patient, are experiencing mechanical structural back pain or not. That helps me a lot. The other thing that I've found useful, and there's been some papers in the literature recently, is whether the standing radiograph looks different from the MRI as it results, as a function of spondylolisthesis. And there are clearly patients who have a very minimal spondylolisthesis on you know, their supine MRI that have quite a significant spondylolisthesis, or even some angular change on their standing X-ray, and that's important to me. So I think those two things probably govern my thinking on this more than anything else. But while I have both of these surgeon experts on the podium, I might just ask both of them, Norm and Greg, what do you ask of patients to try to understand whether they have mechanical back pain or not?
So I ask similar questions as do you. I ask them, is flexion something that worsens your back pain, for example? I likewise find that when patients are asked, do you have back pain, they say yes, but when you try to elicit where exactly it hurts, it more often than not is in the buttock and not in the back when they're walking. And they're fine sitting down, they're fine standing up, and it's only after a period of time that they feel it. So in those patients, when they hear a comparison of what a decompression versus a fusion might be like, and I'm able to give them at least my personal statistics of how often people will come back to have a fusion, and obviously it is biasing them, but they more often choose the decompression, and few of them end up with a fusion. And I have a feeling is because most of them really never had back pain in the first place.
Yeah, I think the location of the pain and whatever's inciting it, like prolonged ambulation, but one of the things that I find very interesting and helpful is their pain history, because a lot of these people tell you, oh, they've had 30 years of symptoms, but what is it that now brings them to see me? And they say, well, my back pain is getting worse. When you delve into it, it's that pain that's radiating to the gluteal area that's started in the last 4 or 5 years, but have been getting dramatically worse. The kind of midline axial pain isn't much different than it has been in 30 years. To me, that's someone who has more claudatory type back pain than mechanical back pain, or a combination, but the claudatory back pain is what is prompting them to get treatment versus the mechanical back pain, which is probably hadn't been changing much over the decades.
I think one of the points that Greg made that I thought I'd just illustrate a little further about what patient expectations are. I don't have films to show you, but there was a internist from my hospital who came to see me about 10 years ago with a grade 1 spondylolisthesis that had all the radiographic features that would lead us as surgeons to say, you need a fusion. And he was 66 years old, a pretty active guy, and had about 3 or 4 millimeters of motion with flexion and extension, had fluid in his facet joints, had a pretty plump disc, and had a tight single-level stenosis. So, a very straightforward lateral fusion or TLIF kind of case. But as I sat down to talk with him about what his desires were, he said, look, I'm an internist. If you say you can do a minimally invasive decompression on me, same-day surgery, I go home, and I'm back in my office seeing patients in a week, that sounds pretty good to me. If you tell me that, I do a minimally invasive TLIF, and I'll be back at work in 4 to 6 weeks, as an internist, that's a bigger deal. And I lose part of my practice, it's gonna be tough on my partners, and I don't have any back pain, even though you say these x-rays show all this motion and so forth. I just don't feel it. So he had a minimally invasive decompression, did great. But 10 years later, his neural foramina were tighter, and he started developing a foot drop. And so again, as a surgeon, I thought, well, this is a failure. I did a decompression on him, he did fine, but now he's got a foot drop, and now he's 10 years older, and so forth. But interestingly, from his perspective, he said he still goes for a walk with his wife, he walks his dog, he's retired, and he's happy. He doesn't have any pain. And so I think, while that sounds pretty counterintuitive to the way we look at cases in our office, sometimes I think it really pays to listen carefully to what your patient wants and what their expectations are, and it oftentimes will change your surgical management. So just as an aside to what Greg was talking about.